opening the door wide to new possibilities, hope of real breakthroughs and understanding more big ideas than we could have ever imagined. These are the biggest grants we've ever been able to. We are going to come out of this with some breakthrough ideas. Focused solely on neuroendocrine tumors. You are not alone. We are all with you on the board. So with that, the last segment here, post-coffee break, but help yourself whenever the spirit moves, is really about living with NETs. And so we want to talk first with Dr. Yang, who you've just met, about managing some of the symptoms. And then we're going to get an update, and I know there are a lot of questions about nuclear medicine, from the World Theranostics Conference, which just ended yesterday, or I guess in Australia the day before yesterday, since it's tomorrow there now. But anyway, it just ended, and Josh Mailman, who many of you probably have seen or heard or will become aware of, a patient group leader from California, is there. He's one of the world's almost experts now, even though he's not trained in nuclear medicine, on nuclear medicine. He's started a website on PRRT, prrt.org, if you want to look at it. And his own experiences populate articles that he's written about patients. He's very knowledgeable about some of the issues that were raised in the last discussion, especially around theranostics, and there's news to report from the latest conference on that just yesterday. So he'll be with us. And then we will finish up with Dr. Modell talking about other ways of living with a chronic disease, living with a chronic cancer. So I know some of you have to leave, some of you are getting coffee, but we are going to get through that program, make sure those of you who are here have the benefit of all those wonderful speakers. So without any further ado, let me ask Dr. Yang to come on up if we're all set, and talk a little bit about managing symptoms.
Good afternoon. I want to thank the foundation and Dr. Wolin for inviting me to speak. It's a pleasure and quite a privilege. We're going to be talking about living with neuroendocrine, living with NETs, the GI symptom management. A lot of it is going to be a review, but particularly because it's from the GI tract, I thought it was noteworthy to review. So for the patients with neuroendocrine tumors, your friendly gastroenterologist is probably the first physician that you'll meet in your long journey in your multidisciplinary management. Most of the time, patients come to us not because they know they have a neuroendocrine tumor, but actually because they have other types of GI symptoms, whether it's vague abdominal pain, whether it's heartburn, or maybe their primary doctor sent you to the gastroenterologist because you have anemia that you didn't know about. So there's a variety of ways that you come through the door to see us, and then sometimes you come out with the diagnosis of NET. So just to review, neuroendocrine tumors come from primarily the GI tract, and it's really divided into embryological roots. The foregut, which is the stomach, and the proximal duodenum. As you can see, most of it is from the midgut, which is the small intestine, the appendix, and the proximal colon, so that's usually up to about the transverse colon, and then the hindgut, which is the rest of the colon, and then the rectum. Other parts of the GI tract that are involved that are not from the gut, which are different from the luminal system, is pancreas, obviously, as you know, gallbladder, liver, and then don't forget about the genitourinary system. So it can involve the kidney, testes, ovary, and even the cervix, lung and thymus, as we talked about as well. So these are, I'm just going to go through some pictures about what they actually look like in your GI tract. Like I said, most of the time for GI carcinoids, you're not going to come into the door because you have symptoms. Most of the time you come because there's something else going on, and for whatever reason you have to have a GI workup. So most of the time from a neuroendocrine perspective, you're usually pretty asymptomatic. Most of the time patients come because they have heartburn, as I mentioned, or other kinds of symptoms that warrant an endoscopic evaluation. And then lo and behold, when we do an endoscopy, we'll find these incidental tumors. So if you can see the one on the left, that's a type 1 gastric carcinoid. Usually that's in a benign course, and it's usually involved in people who have autoimmune gastroenteritis. And the reason why carcinoid tumors develop in their stomach, and usually it's multiple, is because of the hormone phenomenon. Antibodies attack your acid-producing cells. You don't make acid. The stomach thinks there's something going wrong. It produces more gastrin, which is a trophic hormone, and it allows all the stomach cells in your stomach cells to grow, including your enterochromaffin cells. So that's why you get carcinoid tumors in your stomach. However, the one on the right is a type 2 or type 3, actually, carcinoid, which is a sporadic gastric carcinoid. Those are very, very different from the type 1s. They are not associated with an autoimmune phenomenon. They are, just as it sounds, sporadic. You get them for no good reason. It just happens. The difference and the reason why you have to differentiate it is because the one on the left, as I told you, is benign. It's a secondary reactive adaptive phenomenon. The chance for metastases is very low. The one on the right, no matter what the size is, if it just doesn't belong there and has no association with inflammation, it needs to go no matter what the size is, because the risk of metastasis is very high. Then you go into duodenal neuroendocrine tumors. Again, these are usually incidentally discovered. Patients don't have symptoms. Sometimes you would if it's the type that produces peptides. So, for instance, gastrinomas and Zollinger-Ellison syndrome, which we kind of mentioned. If these tumors are secreting massive amounts of gastrin, you run into the same problem. Gastrin, as I said, is a hypertrophic hormone. And so if you don't have the autoimmune variety and your acid cells are working, what happens is that this hormone drives the acid production in your stomach, and you have pHs in the stomach that are less than 2 most of the time. Normally in patients, it's around 4 or 5. So your stomach is more acidic, and that gives you a predilection for developing ulcers. So these tumors are very different because most of the time they are going to be symptomatic. If you have the gastrinoma type, you'll have ulcers, you can bleed, you can have pain. So these can be symptomatic in that realm. The picture on the right actually is a unique picture of actually a carcinoid that's involving the ampulla. So this is also very rare, but ampulla is it's in the location of the duodenum, which is actually very critical. It looks like a little belly button, but it is where the cross-section of the bile duct and the pancreas duct exit into the intestines. So if you can imagine, if you have a little tumor there, no matter what the size is, it's the wrong place at the wrong time. And so you can develop jaundice, pancreatic insufficiency, and problems in that realm. So most of the time, those things will be symptomatic. So if we travel deeper down into our small intestine, this is sort of the place where we have trouble finding things because it's not within the traditional reach of endoscopy. So the small bowel is over 25 feet long, and most of the time you're not going to have symptoms from this either unless they become large enough to cause obstruction, large enough to cause intussusception, which is basically a telescoping of your small intestine. So basically the tumor acts as a lead point and it causes weight upon the small bowel, and the small bowel telescopes upon itself. And if this happens to you, it's a spontaneous thing. You'd have severe pain and you'd have to come to the emergency room because it's not something that you can handle at home. However, neuroendocrine tumors in the small intestine don't have to be that dramatic. They can be as small as the picture on the top right, just a little bump. Doesn't look like anything. It doesn't look anything worrisome, but what happens is that sometimes as the tumors originate deep in the small bowel layers in the submucosa, it outgrows its blood supply, and so then it becomes thin-walled at the mucosa, can ulcerate and bleed. So sometimes the bleeding can be very dramatic, where you actually have blood per rectum, black stools, or sometimes it can be very subtle. You never see blood, always have brown bowel movements, but when you go see your primary doctor, they tell you that your iron levels are low. So those are the myriad of presentations of small bowel tumors. So they can be insidious, never know you had it, never had symptoms, which is why most of the time it's very difficult for even us to find them. Or they can be very dramatic, and you can come to the emergency room for bowel obstruction. So the presentation is wide. So those pictures that I had shown you before, these are capsule endoscopy images where I mentioned to you that you swallow a camera, it takes millions of pictures of your small intestine. And as you can see, the visualization is pretty good. However, the limitation is that you can't make a tissue diagnosis. So even though you see a lump or bump on a capsule endoscopy, say you don't have liver mets, say your blood and urine markers are normal, say you even got an octreotide scan and it was negative, you're stuck with this problem. You don't know what it is. All small bowel tumors don't have to necessarily be neuroendocrine tumors, and so sometimes you get to the point where you're in a diagnostic quandary, and that's again where the gastroenterologist comes into play. This is an image of a neuroendocrine tumor in the terminal ileum. As you can see, the images are much better because you're actually directly looking at it with an endoscope. And with this lesion, it's ulcerated. You see there's a blood there. So these are the types of lesions that also can be symptomatic because they'll come in, again, with anemia or bleeding. Most of the time you won't have pain because these lesions can be small, but sometimes you can. So in ileal lesions, as I was mentioning before, it's actually very interesting. I've had a lot of patients who've come in and they've found it incidentally when they come for a screening colonoscopy. So in the era of screening colonoscopy, we've made strides in increasing the diagnosis of colon cancer and diagnosing it early. But on an incidental note, we've also been able to diagnose neuroendocrine tumors. And there's been a paper actually that mentions in the era of screening colonoscopies how we've found ileal neuroendocrine tumors and have found them at an earlier stage. So that's something that can be exciting. But for this picture and for this, what we would do is if it's within reach of colonoscopy, you have your diagnosis there. And as you can see around the area, that the mucosa is a little dark because that's tattooed, so marked for the surgeon. And if it's not within reach of a colonoscopy, we can do deep enteroscopy. So what that is, I don't know how to play this. Yeah, thank you. So it's basically a procedure where it's a longer camera and we use an overtube which has a balloon on it. Whether you have one balloon or two balloons, it's just a technical or procedural issue that's institution dependent. But it allows you to basically travel deep into your small intestine and able to, in a push-pull fashion, where you're pleating the small bowel closer to you. So you're just bringing small bowel closer to you so that you can look and evaluate through all the deep small intestine. Normally, in endoscopy, you're only seeing about 5% of the small intestine. So there's a whole lot of small intestine that you can't see, that you can't access unless you do something like this. So that's sort of where the challenge is when people come in with neuroendocrine tumors and most of their diagnosis is still left unsaid because this is the area that's troublesome for us. And this is sort of what it looks like live. As you can see, that just traveling down deep into your intestines. So moving on to the last area of your GI tract, rectal neuroendocrine tumors. So as I was mentioning, these are also very asymptomatic most of the time. They're so tiny. They're incidentally found most of the time on screening colonoscopies. They look like a polyp. And they're biopsied and removed sometimes like it is a polyp, but they're obviously very different in biology. Sometimes if they're large enough, they can bleed like other neuroendocrine tumors in the GI tract. But most of the time, as I was saying, from some papers looking at our era of diagnostic screening colonoscopies, we've found these rectal carcinoid tumors, and there's been a shift of finding them in an earlier stage where they're smaller. They're limited to the submucosa. And the good news is that sometimes when you find them and they're that small and you stage them to be early, they can be removed endoscopically for cure, actually, so you can avoid surgery. So that's one of the nice things that a gastroenterologist can offer for you. And just quickly, just to talk about functional pancreatic neuroendocrine tumors, because obviously if they're secreting specific hormones, they're going to give you symptoms. It depends on which type of hormone tumor that you're dealing with, but it has symptoms all that we've mentioned today. But I just want to mention that there's other things that happen besides your GI tract and flushing, some things that happen to your skin, all different types of diarrhea, which I'm going to be talking about, and gallstone disease. Don't forget about gallstone disease. So symptoms of neuroendocrine tumor are highly variable. It depends obviously on where it comes from, what it's secreting, how big it is, etc. But most of the time, as I was saying, it's usually indolent for many years and asymptomatic, and so that's a good thing. So it's sort of dealing with what's the other spectrum, which is what we've been talking about all day. Carcinoid syndrome occurs in 10 to 20% of patients with neuroendocrine tumors, mostly in the midgut, as we talked about, and you guys all know what those symptoms are. I'm going to be talking really particularly about diarrhea. Most of the time, carcinoid syndromes, as you know, happens because there's liver metastases from the midgut tumors, and again, the pathophysiology and the reason why is because the peptides are circulated through the portal system. The gut's blood supply goes to the liver. The liver is like a recycling center. It processes things and then sends out stuff out into the systemic blood supply. So if your liver is not functioning because of metastases, it can't process those peptides. It goes out to the circulation, and then that's why you feel the way you feel. However, just to note that you don't have to have liver metastases to have these peptides in circulation to cause you symptoms, and that's because they're not going through the portal system. So genitourinary presentations, pulmonary, as we talked about, or even if you don't have liver mets, but you have a small bowel tumor that's causing significant peritoneal or retroperitoneal fibrosis or involvement, that in and of itself can also cause symptoms. So it doesn't necessarily have to mean liver mets. So carcinoid syndrome, as we know, is a secretory type diarrhea. It's independent from flushing, so you don't have to have the two of them go together. The diarrhea is watery to loose. It's never bloody, and it can be high volume. It happens at night. It can happen even if you don't eat, which is why you can differentiate it from other types of diarrhea. Because usually there's not a nocturnal component, and usually if you don't eat, you won't have diarrhea. But in carcinoid syndrome, obviously it's different because it's hormonal. And then because of the excess volume loss, you had problems with your electrolytes, including hypokalemia. So there's a multitude of treatments that are targeted to the different kinds of diarrhea that can happen. So the sort of take-home message today is actually that not all diarrhea involved with neuroendocrine tumor is secretory or carcinoid syndrome diarrhea. When you have diarrhea, that's probably one of the major diagnoses, but as a gastroenterologist, our job is to make sure that you don't have diarrhea for other types of reasons, because even though you have neuroendocrine tumor, you could have other plain Jane type diarrhea problems. So it's important to rule these things out. But what is important to mention, and we sort of talked about it very briefly in the morning, is that don't forget that you have to supplement your vitamins and particularly look at your diet when you have carcinoid syndrome. So if you're revving up your system, your tryptophan levels, which you get, are now being targeted towards making all this serotonin. You're not going to have enough to make to convert to niacin, which is B3, your B3 vitamin. Niacin is usually from animal products, so chicken, steak, fish, vegetables. If you have that, then you should be fine. But most of the time, if you're thinking about your, if you have serotonin syndrome and you're making tons of serotonin, you're really going to deplete your niacin supplies. So just make sure that that's always on board in your diet. And again, you can have a diarrhea associated with pellagra, which is a niacin deficiency, and also other things like dermatitis and dementia. The dermatitis is usually an erythematous, crusty skin involvement, usually of the facies around your mouth. So it's very different from the other types of skin manifestations that can be associated. So I always get questions about probiotics, right? So probiotics is such a hot topic. Everyone wants to be on it. Everyone wants to eat it, buy it, I don't know. But I can tell you, though, that there's no data right now about the role of probiotics in neuroendocrine type diarrhea or carcinoid syndrome. So for now, I would say if you'd like it because you want it for your normal digestive system, that's fine, but there's actually no data about probiotics for carcinoid syndrome. Everybody knows about somatostatin. An interesting study that I ran into is a case report about actually using Zofran, ondansetron, for carcinoid type diarrhea. So it's a different type of serotonin antagonist. We usually use it in the oncology world for anti-nausea, but there was a small case study that actually found some improvement in patients' diarrhea just from taking some Zofran. So that might be something that you may want to try if you're sort of up in a creek and your diarrhea is not controlled. Of course, anti-motility agents of all sorts is applicable here. Loperamide, things like that, usually added on top of other treatments is safe. And then the last thing is about pancreatic enzymes. So carcinoid syndrome doesn't really have anything to do with pancreatic insufficiency per se, because again, it's a hormone thing. But pancreatic enzymes are going to be important if you've had pancreatic surgery and you have pancreatic insufficiency from that, or if you're having some issues with absorption and malabsorption from. So these are the things that you have to think about. But pancreatic diarrhea is different than carcinoid diarrhea because it's a steatorrhea, which is a fat malabsorption. It's not secretory, which is watery. So just to quickly talk about somatostatin, even though everyone's on it and for their management, don't forget that in and of itself, it can have some side effects. And for the GI type side effects, the problem is really gallstone disease. So it's basically shuts down your GI tract in a nutshell. So your contractility slows down, your digestive enzymes are shut down, including the pancreatic enzymes. It prevents pancreatic secretion. So that's how you get multitude of different types of diarrhea. So that's where the fat malabsorption comes in. That's where the enzymes might come into play. And you get all these nonspecific symptoms of bloating, discomfort, nausea, vomiting. So that's something to keep in mind because that's really what somatostatin does. It shuts down your GI tract. The other thing to mention is that say you go for surgery for liver metastases, they're going to also take out your gallbladder. And when that happens, not all the time, but in 5 to 12% of patients, you can get diarrhea, which is a choleric diarrhea. What that means is that your gallbladder is a storage for bile acids, and it allows you to digest fat. And so if you don't have your gallbladder, what happens is that in the short term, all of this bile acids that was really being reserved in your gallbladder is now being introduced into your intestine, and it causes water to be drawn into your colon, and you get a diarrhea from that. Usually it self-resolves, so you don't have to be on treatment, but sometimes some patients are a little bit more sensitive. They require treatment, and usually what we give you is a cholestyramine, which is a bile acid resin. It just binds it, and so it prevents it from causing water to be drawn and having diarrhea. But like I said, most of the time this resolves on its own and you don't need treatment. The other scenario is that if you've had surgery, so say you've had a terminal ileal or ileal resection, and now you're sort of living with this diarrhea. And most of the time, if it's just an ileal lesion, it's small, they won't take that much of your small intestine. But what happens is that the terminal ileum is a very critical location where your bile acids are reabsorbed into the body. and recirculated. So what happens is if you don't have that area, an opportunity to reabsorb it, you're going to literally poop it out. And again, all that excessive bile acid is going to draw water into your colon, and you're going to have a secretory diarrhea. So again, it's sort of the same presentation as carcinoid syndrome because it is a secretory diarrhea, but the pathophysiology is very different. So again, in this particular instance, bile acid resins could help as well. Don't forget, again, B12 vitamin is absorbed in this area of the ileum, so you have to make sure that your B12 levels are good and you're supplementing. The other recommendation here is that you want to reduce your fat intake because that's where the bile acids come into play. And so a low-fat diet would really help in this situation. So if you go into the other area and you have extensive small bowel resection, so say you had multiple tumors in your small intestine, they had to take out or there was it was causing large fibrotic reaction into your mesentery, they're going to take more small bowel than just the tumor. And usually this is really rare in the neuroendocrine realm, but if they take more than 100 centimeters of your small intestine, then you get into a problem of short gut and malabsorption because there's just not enough area of small intestine to absorb your nutrients. So that's protein loss, carbohydrate loss, fat malabsorption. So this is a little bit more of a problematic area because we obviously can't give you more small intestine to absorb your nutrients. And then one last thing, this is sort of like a hot topic now in GI, is called small intestinal bacterial overgrowth. This can happen, in any patient, but in the context of neuroendocrine tumor, what happens is that you get bacterial overgrowth in your small intestine. And normally, your small intestine really doesn't have that many bacteria. It's really primarily only in the colon, particularly anaerobes. So as you can see here, the colon normally has 10 to 12 organisms per milliliter. And in the intestines, it's really only 10 to 4, 10 to the 9th. So it's a much less bacterial load. But what happens is that if you, again, had a ileal carcinoid, they resected it, you don't have your ileocecal valve anymore, which is sort of your doorway between your colon and your intestine, all of that colonic bacteria is going to wash up into your small intestine and colonize that area. So your small intestine is really not used to that. It's not a normal microbe for them. And so this bacteria festers, it produces gas, you get bloating, cramping, abdominal pain, very nonspecific symptoms, but very uncomfortable, obviously. So this is easily diagnosed with a breath test. So you basically breathe into a bag and it measures your bacterial production. And so if it's positive, then we put you on a short course of antibiotics. But the other ways that you can get SIBO is anytime that you have stasis. So say your terminal ileum is fine and nothing happened with your colon, but maybe you had a huge fibrotic reaction, or maybe you had surgery and you had adhesions now and your gut's just not working as well. The motility slowed down because you're on somatostatin. So all of these things are sort of like a setup for bacteria to just stay there and be stagnant and cause havoc in your GI tract. As I mentioned, that the diagnosis, the diarrhea can be multifactorial. You can get abdominal pain and bloating, which is really uncomfortable. And what happens is it leads to intestinal inflammation and malabsorption, as I talked about. And it's for everything, for fat, for carbs, for proteins. So really the issue is twofold. Diet modification, so if you try to stick to a low-carb diet, because the bacteria really love to break down carbohydrates, and that's where you get the bloating symptoms. The other thing is to try to keep a high-fiber diet. The other thing is that don't forget that you can develop lactose intolerance, it could be or could not be related to your neuroendocrine tumor, but don't forget that sometimes you can get lactose intolerance developed as an adult. So say you didn't have any problems with dairy products 5 years ago, and then you just happen to have gone through neuroendocrine management, surgery, whatnot, and then later on you notice that you really have problems processing dairy. So it's just something to sort of think about, and it's very easy to diagnose and treat. You just avoid it and see what happens if your diarrhea improves. And then if you want to enjoy dairy products, then you just supplement it with a lactate supplement that you can get over the counter. And again, the treatment for SIBO is antibiotics. Usually the goal here is not to get rid of the bacterial flora, because this is actually natural and part of your body, but it's really just to reduce it in places where it's not supposed to be. So usually you just do a 7 to 10 day course. Our antibiotic of choice is rifaximin because it's not systemically absorbed. But the problem with rifaximin is it's very expensive. So there are alternative antibiotics there. And the one last thing is that the recurrence of SIBO is pretty high. It's about 30% at 6 months. So, usually what happens is that we might put you on antibiotics, see how you respond, try another course, or sometimes what we do is if it's really prolonged and recurrent for you, then we'll put you on a long course where you alternate antibiotics or alternate weeks usually. So in summary, neuroendocrine tumor spectrum from GI symptomatology is very wide, and it can be either indolent and asymptomatic for years, or it can go all the way up to severe diarrhea. Diarrhea, as everyone knows, is from carcinoid syndrome, but don't forget, it's not all diarrhea in neuroendocrine tumor is from carcinoid syndrome. Thanks.